Good afternoon. I think it's probably more like a refresher course because everybody knows about Shockwave, but still. Um, so it's going to be a quick talk. So mainly the challenges, which is real problematic in intervention of all these lesions, is essentially calcium, and many challenges that are associated with calcium and its complications include in treatment options is dissections, perforations, recoil, embolization, stent crush, and of course large bore accesses. So the whole concept of lithotripsy, I'm sure, comes all the way 30 years ago from a kidney stone treatment, the sonic pressure waveforms, which preferentially affects the hard tissue and disrupting the calcium itself, leaving the soft tissue pretty much undisturbed. And what they did is translated the same technology into the intravascular component, where they involved using a balloon and sound waves with emitters in it, thereby helping with treatment of the vascular calcium per se. So the mechanism essentially where it involves is delivering a catheter, inflating up to with low pressures. The low pressure technically generates effective pressure of 50 atmosphere by these sonic beams, which are in these emitters, which then cracks the calcium and then it expands the vessel. And that was nicely shown by Dr. Vermani in a micro CT with the pre and the post intervention, where you can see the calcium cracks both in the superficial and the deep calcium system, thereby increasing the elasticity of the vessel and thereby helping with the vessel prep. I'm sure you've seen this video many times, but again, the same concept of creating these small expanding and collapsing vapor bubbles, which create a short burst of sonic pressure waves, and then thereby affecting the calcium as well. And again, to demonstrate how it differentially works on the harder or more calcified segment, thereby by leaving the softer segments not damaged, is where the differential action of these lithotripsy components happen. This is on the left side, which is heart to heart, and the right side is the soft gel, where it really doesn't affect the non-affected or non-calcified segments. This is your basic setup of your shockwave device. The good thing is now they're coming up in multiple different sizes and forms. You have the shockwave L, which is meaning for large accesses. I'm sure people who do large bore accesses and other devices, it comes in 8, 9, 10, and 12. You have the medium, which is more for your SFA and the pop. And then you have the shockwave S, which is for below the knee lesions extending from 2.5 to 4 vessel diameters. Again, the same form of various entities and vessels being used on, all the way from renal, iliacs, subclavians, coronary, spam pop, and infrapop lesions as well. And there's enough data now to support its use and utility in clinical practice with more than 55 publications, more than 2,000 patients. Everybody knows about the Disrupt PAD trial. So there's enough randomized trials, real world registry, and long-term follow-up to support its use as well. This slide just gives us a brief overview of how the evolution of Shockwave and its trials has happened all the way from Disrupt PAD1 or down to PAD3, both the randomized and the observational studies, and the Disrupt BTK trials as well. Multi-center trials, initially involving comparison between in the de novo lesions, where they compared use of IBL with PTA, and followed up by DCB as well, looking at mainly 1-year primary patency and 2-year follow-ups. The primary endpoint was procedural success, which meaning restenosis rate less than 30%, and the secondary was primary patency at 1 year, which was freedom from CDTLR, and of course restenosis. I'm sure now, like Dr. Parikh talked about, looking at more harder and more specific endpoints is what the goal is. Again, just looking at the superior prep, it was reported all around, either site reported or angiographic reported. The procedural success was significantly higher in IBL segment of the patients as compared to PTA, with requiring less than 44% less in maximum pressure utilization, as well as 77% reduction in type C dissections, which is what we are looking at. And if you look across the spectrum, pretty much there were minimal complications, which we talked about on the front first slide, meaning dissection, embolization, perforations. 77% reduction, we talked about dissections, no real complications of embolization, perforation, or thrombus formation, and also reduced bailout stenting with 75% reduction in the stenting in the IBL arm. Of course, we want to look at the midterm and long-term patency results, which is what essentially we're looking here. And you can see a consistent significant difference between the IBL DCB arm versus to a PTA arm, one at first year, which was 80.8% and 70.9%, and followed up at second year, which still shows a significant difference of 16.7% here as well. So I mean, we talk about randomized trials, which are the ideal patients, ideal scenario, but obviously we're also looking at the observational study, which gives us the real world experience of how a device or any technology is doing. So this was the Disrupt PAD observational study, which was again multi-center, single-blind study, which involved 1,300 patients, almost 1,700 lesions, 30 sites in 3 countries. The patients were followed up for 4 years, evaluated by angiographic core lab, and then they were essentially assessed. Of the patient spread, you could see that 36% of those patients were CLI patients. Of them, 56% were diabetic, and 27% have some form of CKD. The lesions, of course, were very challenging, with 90% of them being moderate to severe calcifications, 31% with CTOs, and an average length of 115 millimeters. So if you look across the spectrum of various vessel beds, the lithotripsy arm performed consistently well, whether it be the lesions, whether it be the vessel beds we talked about, or the complexity of the patients. Looking from iliac all the way down to below the knee, you can see the blue IVL arm doing much better as compared to the popliteal arm, and so as for the below the knee as well. For as any device, we want to look that the safety profile is comparable. So they did also did an exception a safety analysis, and they found an exceptional safety profile, which you can see the dissections, perforations, embolizations, slow flow, abrupt closure, thrombus, all were pretty much essentially zero, both in the randomized or near zero, both in the randomized trial as well as in the observational study. With effective calcium modification in the IVL arm in both the studies as well. So essentially, IVL provides superior vessel prep with excellent long-term results in calcified vessels while preserving the future options as well. Just to give you a few idea, how we've used IVL. Of course, there are multiple modalities where you can use that, but essentially a patient presenting with severe claudication, abnormal ABI, underwent all the non-invasive testing, ended up on the in the cath lab, and here you can see a significantly calcified left iliac lesion. Did an IVL. We used ATO. In this case, went up to 2 and then to 4. This is post-IVL well expansion of the balloon on the left side. And eventually we ended up stenting with excellent good results with no edge dissections or any other complications. Looking at the SFA disease, again, a patient presenting with significant claudication, abnormal ABI, abnormal non-invasive testing after all medical therapy was found to have a left SFA CTO with calcification noted in the mid-segment. We eventually did cross the CTO, used our shockwave to give the deliverability, and then you can see post-shockwave, the results look beautiful and with great minimal spot stenting, but the rest of the vessel looks great. Like we talked about, because of now the availability of shockwave for below the knee tibial vessels, this is a patient presenting with CLI with, you can see, diffuse significant calcified lesions on the anterior tibial with posterior tibial nearly occluded. We crossed the lesion easily as expected. We used our below the knee IVL, the goal being that we don't want to try to stent it, so we did IVL the entire segment, and then you can see just based on IVL and PTA, our result of the AT. So again, disease, but still spasm there. But eventually, IVL does work, has its own utility if used in an appropriate way, a good adjunctive therapy with minimal complications of radial flow. Right? Thank you.